Hi everybody. We're gonna get started. So look, you're very welcome. Thank you for joining us at the Innovation Zone. I'm Mark Cooley and I'm a director at Imperial College Health Partners. I'm joined by my colleague Logan at ICHP and Emma, who's at UCLP. And we are going to talk to you today, just to check you're in the right place, about this stuff. So if you've got a systemic challenge and you want to make stuff happen that is sustained, we're going to tell you that you need some real-world data, real-world evidence to inform and sustain that change. You'll tell us whether we've convinced you by the end, but we're going to talk about two things. In Imperial, we talk about living laboratories, and essentially we're going to describe to you how that's a combination of people needing a particular problem solved locally, using data to do it, and bringing in industry and innovators to support that journey. And Emma's going to talk about putting that in the context of a system that learns about stuff so that you have processes of continuous improvement, and that's learning health systems. So I'm going to get started on the living laboratory approach. And I said to the design team, look, I want these slides to really create a buzz. And I think they took me a bit literally. We had also been talking about how this underpins a process of like cross-pollination of ideas. And again, we've got metaphors that stick. I think what we want to be talking about in this sort of context is we have a data asset in Northwest London that informs what we do, that drives a process of doing stuff in the real world, but that real world change then comes back in the evidence. So there's a process of sort of reciprocity, doing stuff, learning from it, it flows back. And we put this together as a sort of description to ourselves as a living laboratory. So it's got three parts to it. We want to make sure that we are working on projects that are going to, as we said at the beginning, tackle the really systemic issues and do it in a sustained way. And we think there are three major ingredients that are true of things that are projects of this kind. You can only succeed if you are doing something that the local system cares about. If there's no local demand, then you can have bright ideas and well-informed sort of solutions, but nobody cares because there's no pull, because we're not actually addressing something that is a problem locally. So local demand is absolutely vital. If you've got the local demand, but you don't have some data, then the likelihood is you are addressing the wrong problem, or at least you're not clear about where to target your solution. But even if you've got local demand and you've got the data, and you don't have industry partners or innovators who can come and support, it's very likely in our experience that we end up in a position where you try and address the problem with today's thinking. You need to be unbounded by our own current ways of thinking by inviting other people in from different industries, or inviting people in who are trying things at the edge, because that's the way that we will help them learn about what they're doing, and reciprocally we will understand more about the frontiers of what's possible. So when we put that in action, it becomes a sort of a tripartite ingredient set really into a set of projects. And we've done this now in a variety of different instances, focused often on long-term condition management. A lot of that really requires pathway redesign across multiple bits of the healthcare system. And it almost never is resolved by having a point solution. So a widget here or a gizmo there is never the answer to something that is essentially a complex pathway. So this whole process for us of bringing these bits of data, often local clinicians and managers together with innovators, is that we set up design processes where we're iterating discovery, design, deploy, learn about it, do more discovery, redesign, deploy. That process we think is the engine of making change that is useful, and by doing it in practice on the ground, we actually end up changing people's thinking in ways that sustain the changes that we make. So look, that's the sort of theoretical argument that I'm putting to you. Logan's going to touch on a specific example where we've actually done this in practice, and he's going to talk about respiratory hublets and pheno. So if I hand over to Logan.
Great, thank you, Mark. So to carry on from the analogy that Mark used of this being a really important list of ingredients, the recipe for respiratory diagnostic hublets is such. So firstly, what are respiratory diagnostic hublets? Quite important, of course. So they are a means of trying to improve the diagnosis of COPD and asthma out in a community setting, specifically using spirometry testing and pheno testing. Now that immediately raises questions as to how do we operationalize and how do we implement a model like this that hasn't yet been done. We ask questions of appropriate sites to be using. We ask questions of the appropriate size of that patient cohort. What capacity do our services need to be? What resources do they need to have? So that then is where we bring in the key element of real-world evidence. And linking in with our Northwest London Clinical Research Group for Respiratory, the London Respiratory Clinical Network, and a dedicated development group for the Hublet project, we were able to utilize the whole systems integrated care database, which Discover now has access to and Mark's just referred to be able to understand where are our areas of limited access and deprivation perhaps, where are our areas of lowest diagnoses of COPD and asthma currently, and where are our areas of highest urbanization and lowest areas of air quality. So that's where our data imperative comes in, because London, I don't know if you know, has some of the lowest diagnosis rates of COPD and asthma in the country, but the highest levels of urbanization and some of the worst air quality in the country. Now, you don't need to be a clinician to realize that doesn't really make sense. That doesn't add up. There should be some more hidden asthma and hidden COPD in the population than we're currently seeing. So we were informed by that evidence to determine we need an intervention, and we were informed by the evidence to determine where that intervention goes, and later I'll show you how we're informed by the evidence and the data around activity, and therefore understanding, is it working, and do we need to change? I'll also touch on the other two parts of the model, which are, of course, incredibly important. The local system demand. This was delivered through Northwest London Integrated Care System, incredibly committed stakeholders, and, of course, the Respiratory Clinical Network and borough leads. So this was heavily primary care driven, and we were desperately needing to get those borough primary care leads and PCN clinical directors on board. And the third area, the supply-side partnership, this was largely delivered through our inclusion of pheno testing into the actual offer of the respiratory diagnostic hublets. This was supported through the fact that pheno is an accelerated access collaborative rapid uptake product, meaning that it had the rubber stamp, and the AAC and NHS England had done an awful lot of due diligence, meaning that doors were already open and the clinical and operational system in our ICS were more willing to engage with industry than perhaps typically they may have a few years before their pheno being listed as a RUP. We were also able to include spirometry industry providers. And together, by bringing those into the room and making them part of the development of the Hublet model, we were able to accelerate sharing of best practice and learning from other areas where they'd already implemented this technology. We were able to share training and be able to go into sites using the staff and resource of industry to be able to upskill the staff to deliver the Hublet model. They're the three together, and without any one of those, so without pheno and the suppliers having that rubber stamp from national, but also just being engaged and being willing to help support the system, without that local system demand and want, the respiratory clinical network at a regional level, but also the ICS being committed to meet those requirements, and probably most importantly, that real-world evidence of understanding the need and understanding where that's best placed and what the impact therefore may be, we've been able to deliver both a sustainable but impactful piece of work, which is in its early days, and we're going to be constantly looking to the data and the activity to determine if it's going as hoped. But it's an example of real-world evidence and data, back to the main question of this talk, not just necessarily being an output of a project, but being something that should be built into the project. It should inform whether the project is born in the first place, how it is then delivered, and then whether it continues, it scales, how it scales. It's there and it's intrinsic throughout. So whilst equally weighted, it would all fall apart without this top linchpin, which is that real-world evidence. So I'll touch on the role that we played as ICHP in Northwest London, and arguably as well, real-world evidence is involved in all 6 of these. So we played the role of an honest broker between the NHS and industry, as we do as an academic health science network and as a partnership organisation across Northwest London, supporting and catalysing innovation. We utilised our networks both locally with clinical reference groups, the clinical leadership groups and the respiratory clinical networks, but also the academic health science network itself, the AHSN, sharing with the other 14 sister AHSNs across the country. We were policy advocates, acknowledging that there were policy coming out relating to COVID recovery. The London Respiratory Clinical Network were bringing out specifications for respiratory diagnostic spoke services which Hublets deliver. We pulled all of that together, collated it, and then delivered it back in a much more digestible form to our system. Data and pathway mapping. We've been involved in ensuring that we have the appropriate templates, because that's a really important part of this work, is making sure we have the right templates with the right codes behind them, because without the right codes, we have no idea what data we're pulling. It may not be accurate data. How do we ensure that that data we're pulling can truly be attributed to the activity of the Hublets and not just a GP practice out in the community being innovative on their own, which we don't discourage, but we need to be able to identify what is individual innovation and what is our sector-wide scalable, sustainable program of work. And the pathway mapping piece as well. Understanding, if we're going to need this capacity and we're going to have this activity and this demand, what will that mean in terms of onward referral? Because we're going to have a responsibility, once we identify these patients with COPD and asthma, to then refer on to pulmonary rehab perhaps, to refer on to integrated specialist teams at secondary sites, to eventually refer on to community diagnostic centres or hubs. We need to be informed from the beginning, before even integrating into those services, that there are those interdependencies and what might we then be asking of those services. Being a constant, that's simply just being around and being there, being in all of the forums necessary. The Respiratory Diagnostic Hublet Development Group, we were a key coordinator in that, setting up data subgroups, pathway subgroups, template subgroups, subgroups galore, quite tiring, but incredibly important, so incredibly important, and ideal if it's that one individual, that linchpin that's doing that whole role. And then finally, we really found ourselves benefiting from the fact that we have a one Northwest London or one team approach. So whilst not part of the integrated care system, we're very much embedded in that team and that way of working. And any advice to those in the room looking to try and do sustainable work and change at a system level, obviously it goes without saying the ICS are the key ones to be working with, but try and embed yourself in their way of work, speak their language, be where they are, and that's a key way to delivering this sustainable change outside of the real world evidence. But another important thing is the way that ICSs are being set up now. If you want access to that real world evidence at that system level, the ICS are going to be the ones holding it and controlling it and helping you to actually access it in the first place. So again, really key that you are a one team and you have that trust and that co-working spirit. And then finally, just to acknowledge some of the evidence that we've managed to capture that didn't go into the project, but around how it's actually going. So this is a snapshot of Hillingdon, who are delivering their hublet in Northwest London through a unique drive-through model. This was informed by COVID, and they are having their tests conducted in cars. And whilst these numbers are low, and yes, we shouldn't always look to just one key metric when we're doing these analyses, but I think today, it's important to just acknowledge 69% of all of the patients seen at this hublet in that given time period had possible obstruction. So what does that mean? That means that given the spirometry and pheno-testing conducted on the patient on that day, they likely had COPD to a varying level of severity. That patient, so 69% of those 32 patients that had spirometry, they potentially wouldn't have been identified until they'd ended up in A&E due to an exacerbation of COPD that they triggered unknowingly. They potentially wouldn't be identified until they'd been put on a whole host of salbutamol inhalers because they were incorrectly diagnosed as having asthma because they were exhibiting breathlessness. That also asks questions around sustainability of misuse of drugs and medical optimization, medicines optimization. So again, this one real-world evidence piece is actually informing huge different parts of the sector as long as you've got that one coordinator linking those dots for you. And I also want to acknowledge something that can go unforgotten, and it's the qualitative feedback. The qualitative feedback from the patients. they much prefer this model. They like the fact that it's somewhat removed from the GP setting. They like the fact that there's flexibility. So the drive-through model was a weekend service, but there was also one on a Friday, always delivered outside of work hours. Something that GPs, given their structure, sometimes struggle to be able to do through no fault of their own. It's just how they're set up. So having this integrated approach to delivering in a different way helps everyone. And this middle column here is the important feedback from the actual team delivering itself. And they all acknowledged, very high level here, but it's a good skills mix. They felt that there was a dedicated member of the team. They've even pulled together a WhatsApp to be able to share learning. And from this and from similar feedback from other sites, we're going to be implementing that when we look to scale to ensure that these good little bits that aren't necessarily numbers, but they're still valuable pieces of information for us to gather, inform rolling out in other areas. So hopefully I've not babbled on too long there, and hopefully to wrap this up, I've managed to evidence the fact that real-world evidence can be quantitative and qualitative. It can be at any point in a project's lifetime, but it always needs to be constantly being referred back to. It shouldn't be the sole deliverable, and it shouldn't be the sole input. At this stage, we are going to go to questions on this talk specifically, so about the wider Living Lab approach, or the respiratory diagnostic hublet specifically, at which point I'll then hand over to Emma for their talk. So are there any questions? And there'll be a remote mic coming to you guys if there are any.
I'll break the duck. I'm Luke Redmond from London. So it's great to see this and hear it. I guess I have a question about scale, because you talked a bit about scalability. So how do you actually go about scaling this so that you're covering what you define as your whole population? And then, you know, in the ICS next door, they were doing it a different way. How do you normalize all of that and sort of work all of that? Because they're difficult human problems, really.
Absolutely, and a really useful question. So I'll answer the second, if I may. So how do we ensure that standardization, I suppose, across a wider extra ICS patch? Well, it's something the London Respiratory Clinical Network are fully aware of, the challenges, and they actually run a London hublets meeting. They're quite prescriptive in the core offer of a hublet. They do allow for local nuance, but we're constantly sharing. At the moment, it's once a month between all of the hublet leads in each ICS in London. So that's North West London, North Central, North East, South East and South West. And then we're ensuring that North West London, it's slightly further ahead. We have some templates already produced, and we will just share them with the other ICSs. We've identified some codes which work for that data capture, so we'll share those with the other ICSs. So it's very much a sharing environment and ensuring that that standardization is actively done simply by no one holding too closely and too tightly onto their resources. And to answer your first question around how are we going to inform scale, being honest and transparent with this room, it's hard and it's difficult, and we don't yet know the answer to that, because of course it's all largely going to come down to finances. But how we understand the finances we're going to need, well, that will be determined by activity we've seen to date. Is it higher or lower than the activity we originally planned for this financial year? It's also going to be informed by what offer we want to actually give. So at the moment, we're giving a basic offer where we do interpretation, but we're looking to scale up to a gold standard or an enhanced offer where the hublets actually diagnose there and then. So the GP won't need to then interpret the results of the hublet and do that diagnosis. What will that need? That will, in theory, need some more Band 7 specialist time to actually interrogate that testing slightly deeper. It will potentially need some consultant time to support with MDT and onward referral. And how do we determine that? It's again through that community of practice development group approach of bringing together the clinical leads and asking them those questions. It's all of this really comes down to asking the right questions, and I feel like we are, and I feel like the ICS are supported by us in doing that. But right now, we don't know exactly what scale will look like. We just know how we're going to try and approach it.
I might just come on the back of that. There's another aspect of scale here. So we're talking about real-world evidence, and we happen to be fortunate in North West London where we've got a large data set that links GP data with hospital data in ways that allows us to do population health analysis. Other bits of London, I think, would benefit from having that same infrastructure. And we would benefit from them having it, because we would be able to do comparisons outside of or between ICSs that we can't do currently. So we're working as North West London with other ICSs to try and get a similar type of data asset for all of London. And, you know, I think that's a really significant prerequisite for London being able to do sustained change. We happen to, as part of another bit of work, do the largest data deliberation with the public internationally ever. And what London has said to us is, we don't recognise these administrative boundaries. We don't want you to have something in North West London that's not available to a patient in North East or South West or across the capital. So they gave us our marching orders and said, you must make this happen everywhere. And our intention is to make that happen everywhere. So part of the scale is to make sure that the stuff that we can do in North West London because of our data asset is available across North East London. And we're going to need the leadership of the ICS and the region to help make sure that happens. So I think that's probably us done.
Yeah, I think that's time, but please do, by all means, take my email address down. Those that don't manage to, I'm happy to hand it out afterwards if you have any questions on this or the wider approach. But thank you, and I'll hand over to Emma.
Thanks, Logan. So hi, everybody. My name is Emma Mordaunt. I'm an Improvement Projects Manager with UCL Partners, one of the academic health science networks. We're very closely paced to ICHB, and we work in partnership on a lot of projects. So today, I'm going to talk to you about our learning health systems approach. So to start with, what is a learning health system? So to me, a learning health system is really a framework or a mechanism that organizations, or even at a project level, that you can adopt to learn fast and act fast. And I think, as Logan mentioned really clearly, it's about embedding that real-world evidence so that you can make changes really quickly and work in an agile way and adapt the process as you need to. So there's 5 key steps that you need to consider when you're implementing a learning health system. So the first step is about gathering data. And I'd really challenge you to kind of widen your definition of what you think about data in this instance. So look at what you already collect, look at the quantitative data you have that's easily accessible, but also think about how you can gather patient insights and staff insights in a really systematic way so that you can get that more granular data, really understand what is important to staff, what is important to patients, what are the kind of knotty issues in the system that we need to address. The second step is about analyzing these insights. So again, it's about looking at all the insights that you've collected, what themes are coming through, really understand what is working well, what are the big challenges, what improvement ideas are coming out of those insights that maybe we want to test as well. And then bringing these to the decision makers in step 3. So when I say make decisions, it's all about using everything you've done in step 1 and 2 to make informed decisions, so that any decisions that are made can be tracked back, they're backed up by evidence, they're backed up by data. Step 4 is about connecting decision makers with the implementers. So taking those ideas for improvement and interventions, putting them into practice, and testing in real time. And I think, as we've mentioned as well, it's about continually looking at that data as well, so you can measure impact and really kind of adapt the processes as you go, so everything is done in real time. And the final step is about closing the loop. And I guess as we've applied this learning health system approach to many programs now, we've consistently seen that this is like one of the key steps. So there's a few elements to this. Closing the loop is about checking that the interventions or changes you've introduced are reliably in place, that they are adapted if they need to be adapted, that they're sustainable over time, that they address the issues they were set out to address. But it's also an amazing opportunity to feed back the changes and the results that have happened as a result of those changes to the staff and patients that provided those insights from the offset, and to close that feedback loop with the staff and patients and encourage that culture of continuous learning as well. So these are the 5 key steps in the framework you need to consider. I would say at the heart of this as well, and where we've seen it work particularly effectively, is when there's an ethos of working differently, an ethos of continuous learning as well. So I'd say that's central to this being effective. So how does this actually work in practice? So what we do is we consider an array of different activities to gather data. So you'll see the first one is about exploring publicly available data or things that are regularly reported. So as I mentioned before, see what data you already have. Maybe you already have access to a lot of great insights. Maybe you can tailor the metrics, really define what outcomes you're interested in. But also it's important to triangulate these with more qualitative data and look at different ways that you can integrate patient and staff insights into the program as you go. So we regularly go on site visits and we go around and we speak to staff and patients who are involved in the program at all different levels. And we ask them, what is working particularly well? Do you have examples of best practice that we can share with different parts of the system? What's the pebble in your shoe today? What's the big challenges that are affecting you? And what are your recommendations for next steps? So you might be hearing this at a system level. They're recommending we do this. What are the barriers in place that we need to overcome to make this work? And we then supplement the site visits and the themes that come out with one-to-one interviews to get that more in-depth detail about recommendations and how we address some of these challenges as well. And we're really keen to get that wider pathway perspective as well. So not just speaking to the system leads, but anyone from staff and patients who are involved in all parts of the pathway, both acute and primary and community. And where there's opportunities for shared learning and networking as well, we facilitate that, again, to brainstorm challenges and to share best practice. So taking all this into consideration, this is your step one and your step two. So analyzing these into themes, what we do is we look at what's working well, where there are opportunities for improvement, and from this we make recommendations. And typically they fall into these three categories around ways of working, doing things differently, impact on the workforce, and patient experience. And I'm just going to share one example to make this really come to life and how we have applied this to the elective care recovery program in North Central London. So we've been working with the ICS team. So this is applying the learning health system approach at a system level. We've been working with them for over a year now to help them address their waiting list challenges. And I think it's no surprise to anybody here that this is a rather large challenge and something the ICS team really recognized. You can see the stats up here. In May last year, there was over 211,000 patients waiting for elective care in NCL, and over 20,000 of those patients had waited more than 52 weeks. So quite staggering numbers. And the ICS recognized that they needed to work in a different way, think a bit differently. So they really wanted to embed a learning health system approach to address this and set themselves an ambitious trajectory of reaching 110% of baseline by July 2021, so within 3 months. So we did exactly the activities that I spoke about on the previous slide, including site visits, helping them define their metrics, doing interviews, having some system-level workshops. And from this, and I'll show you some of the impact on the following slide. So the impact was brilliant. So we received an average rate of outpatient activity over 121%, so exceeding what they set out to do. And critically, more than 6,000 patients who've been waiting over a year for treatment received the care that they needed. And just to give you an example of something that came out of the site visits and the interviews, and to highlight the importance of including qualitative feedback within your insights as well. So something we found is that it was all the interventions were having a great impact on reducing the waiting list, getting through the backlog, but a knock-on effect was on admin capacity, and they were having massive challenges around that within the system. We were able to give weight to those challenges, really get that granular detail about what are the recommendations, how do we address this. And since the North Central London ICS have put in place a single point of access for a core admin team across the system to triage patients, to make sure the same comms is going out to patients, and to really streamline those processes and include some job development for the admin team as well. So that was just one example that came out of that But I hope that brings it to life. I'm happy to answer any questions that you may have. Thank you.